A 35-year-old man with a history of neurofibromatosis type 2 presents with progressive hearing loss and tinnitus in the right ear. He has difficulty hearing speech and loud sounds. He also reports occasional headaches and waxing and waning vertigo for the past month. Vital signs include blood pressure of 110/78 millimeter mercury, temperature 36.5, pulse of 78 per minute, and respiratory rate of 11 per minute. Tuning fork tests reveal the following. Yes, the answer is a schwannoma. Okay, vestibular schwannoma specifically, since this patient does have neurofibromatosis type 2. Okay, vestibular schwannoma, otherwise known as acoustic neuroma, one of those two. So the features that point towards this diagnosis, okay, it says biopsy reveals cells staining positive for S100 but negative for GFAP. Okay, moreover, the MRI here you can see that is not the image I want, but okay, you can see the tumor over here at the cerebellopontine angle. Okay, so that itself points towards a vestibular schwannoma. So acoustic neuroma can actually affect any peripheral nerve. Okay, schwannoma is essentially a tumor arising from the Schwann cells. Okay, so can arise from any peripheral nerve, but most commonly affects 7th and 8th nerve, especially the 8th nerve, vestibulocochlear, which is why patient is presenting with hearing loss, tinnitus. Okay, and all of this. Moreover, the Rinne's as well as Weber's test, the findings of this, it just suggests that the patient has a sensory neural hearing loss, which is the feature that you would expect in a patient with acoustic neuroma. So it just sort of like, it just confirms your diagnosis. Okay, this is the histology of that. It's already mentioned. Basically, the histology of schwannoma, you just have to remember like one specific thing. It has a biphasic nature. So it has two types. It's called Antoni A and Antoni B. So one is a hypercellular sort of thing, and the other one is hypocellular. I'll just show you the image where it points it out. Okay, so yeah, this is hypercellular Antoni A area, and this is Antoni B with few cells and loose stroma. Okay, so this is a feature of schwannoma. Just remember that it has a biphasic histopathology feature. Glioblastoma multiforme, you can very easily rule this option out because it's mentioned that the patient's histology is GFAP negative. If the patient had glioblastoma, they would be positive for that. Hemangioblastoma, I think a few of you answered hemangioblastoma. Anyways, it's usually associated with renal angiomas. And moreover, the histopathology will be such that there be sort of closely grouped thin-walled capillaries. Okay, so you will not have this sort of myxoid stroma. You will not have this sort of cell arrangement. You just see thin-walled capillaries being closely arranged to each other. And moreover, not associated with neurofibromatosis. Think of hemangioblastoma when they're talking about von Hippel-Lindau syndrome. So VHL, think of hemangioblastoma. Okay, schwannoma we already discussed. Meningioma, histopathology will be very specific for that. If you look at it, you will identify samoma bodies, so you'll know it's meningioma. This case clearly there's no samoma bodies, rule it out. Last one is craniopharyngioma. This one's histology, it usually has both like solid and cystic components. Solid part being the calcification, so usually you'll be able to see the calcifications. And the cystic component is what is described as the machine oil, like, okay, because of the cholesterol crystals and everything dissolved in that. So there's just another thing for that.
Thanks for watching. Please give a thumbs up and subscribe for more.